Bismillah ar-Rahman ar-Rahim. First of all, I'd like to thank the organizing committee for giving me the great opportunity to be with you today. What I'm going to do today is to speak about another sector of neutrophilia other than chronic myeloid leukemia. Actually, the classification of leukemia and lymphoma have been started as early as 1949 during the American Medical Association annual meeting in Atlanta City. And as you see on your right-hand side, the primitive classification of leukemias and lymphoma. Then we start to progress via the FAB classification, WHO classification, till 2022, when we start to have two classifications, WHO, what's called HEM5 and ICC classification. With the WHO classification, this is the myeloid proliferation and neoplasm. We have chronic neutrophilic leukemia and myelodysplastic myeloproliferative neoplasm with neutrophilia, which was previously called atypical chronic myeloid leukemia. This is what we are focusing on today. But we have two important other categories with increased white blood cell count, which is chronic myelomonocytic leukemia and chronic juvenile myelomonocytic leukemia, and they are put in different categories in the classification. In the ICC, as I said, again, chronic neutrophilic leukemia is a category by its own. So what characterizes chronic neutrophilic leukemia? Chronic neutrophilic leukemia is BCR-ABL negative. This is the most important thing to know about it. Clinically, most of our patients, if we see them early, could come without any symptoms for something else, or accidentally discovered by doing CBC for those patients. But they are having persistent neutrophilia, bone marrow hypercellularity, and hepatosplenomegaly, especially splenomegaly in 3/4 of the patients. Isolated neutrophilia have been identified by the WHO as a hallmark or most important manifestation of chronic neutrophilic leukemia. In the peripheral blood, we will see a lot of neutrophils. In the bone marrow, aspirate and atropine, we will have granulocytic predominance with totally absence of any dysplastic manifestations. Megakaryocytes are normal, represented, and the cells show unremarkable morphology to differentiate chronic neutrophilic leukemia from pre-fibrotic myelofibrosis with increased neutrophils in the peripheral blood. So we have to be sure that there is no dysplasia in the bone marrow, no abnormality in the count or the shape of megakaryocytes. The molecular pathogenesis is mainly by positivity of colony-stimulating factor 3 receptors. This is the sine qua non of chronic neutrophilic leukemia. And let us see this receptor, which is something miraculous. سبحان ربي العظيم سنريهم آياتنا في أنفسهم. So let us what this receptor composed of. It is composed of extracellular domain and transmembrane domain and intracellular domain. And each of these three components of the receptor could have a different phenotypic mutation. And look at that. When we have the transmembrane proximal mutation, particularly 618I, this is more common with cases of chronic neutrophilic leukemia and maybe progression to acute myeloblastic leukemia later on. But when we have the phenotypes, different phenotypes of intracellular mutation of these CSF3 receptors, those patients are more liable for myelodysplastic syndrome with subsequent progression to acute myeloblastic leukemia. And this is the most amazing. The extracellular domain mutation is usually associated with not neutrophilia, but neutropenia, particularly with severe congenital neutropenia and chemotherapy-induced neutropenia. So the same receptor, the phenotype of the receptor and the site of the mutation will dictate the disease the patient will develop later on. And according to this article published in 2024 educational book of the ASH, chronic neutrophilic leukemia in the red panel, showing that cases of CML having CSF receptor mutation, more than 80 to 90% of cases, while other different myeloid malignancy are having rare or absent or less than 20% CSF mutation. So the lion's share of mutation of CSF3 receptor is present in cases of chronic neutrophilic leukemia. And these are the diagnostic criteria for chronic neutrophilic leukemia, as I said, for peripheral blood, for the morphology, for the genetic, and we have to exclude BCR-ABL gene, fusion gene, or rearrangement, or any other criteria suggestive of polycythemia vera, essential thrombocytosis, or myelofibrosis. Is it only CSF receptor mutation? No, we have very important 3 other mutations, and the most important of them is B53, which is a bad mutation in any hematological malignancy, and ASXL1, because this is again another bad prognostic mutation in any myeloid malignancy. But we have 6 groups of mutations which could be present in chronic neutrophilic leukemia, either in epigenetic regulators, in splicing factor, transcriptional factor, signaling genes, enzymes, and chromosomal separation regulator. All of these could have mutation in chronic neutrophilic leukemia in association of colony-stimulating factor receptor mutation. So what is the model of occurrence of chronic neutrophilic leukemia? We could start by antigen-inducing DNA damage like TET1 mutation or AXL2, ASXL1, then super added second hit with colony-stimulating factor mutation leading to chronic neutrophilic leukemia, or we could have the vice versa, starting by the CSF mutation receptor, then we will have an add-on of TET2 or SXL mutation. But a recent publication showed that we could have the 2 models together in 2 separate clones or the 2 models on the same cell. So the mutation could happen in different way, leading to the occurrence of chronic neutrophilic leukemia. Now, what is the difference between the WHO classification and the ICC classification? In the WHO, presence of more than 25,000 neutrophil, regardless of the mutation, is a confirmation of chronic neutrophilic leukemia. While in ICC, if we have more than 13,000 with positive CSF receptor mutation, this is confirmation, or more than 25,000 in absence of CSF mutation. I should have less than 10% neutrophil precursor in the peripheral blood and no dysplasia in the bone marrow and less than 10% monocytes. If I have increased more than 10%, I will go to the category of chronic myelomonocytic leukemia. Now, misery likes to be in groups. Misery likes company. So chronic neutrophilic leukemia could be not only the myeloid malignancy in patient, but it could associate other hematological malignancies, like, or even benign disease, like polycythemia vera, especially with the advance of the disease, I mean time-wise, plasma cell disorders, and this is called monoclonal gammopathy associated chronic neutrophilic leukemia. And I have seen a couple of cases like that. One of them, I'm following her up for more than 11 years now, and the monoclonal band is less than 2, but she is having a monoclonal band confirmed by immunofixation. It could have other association like with Sweat syndrome. We all know the Sweat syndrome with myeloid malignancy, autoimmune hemolytic anemia, and interestingly enough, Some cases of chronic myeloid leukemia after quite some time could acquire the mutation of CSF3 receptors and could have the two together. The clone with BCR-ABL fusion gene and a clone of CML with CSF receptor mutation. What's interesting more, or what's really adding to our knowledge, is this paper describing a hereditary chronic neutrophilic leukemia in a family. And this is the pedigree of the family with 6 individuals over 4 generations. And you can see that we are having 4 generations with these cases, males and females. And these are the CBC changes of them, none of them having hemoglobin abnormality nor platelet abnormality, and all of them are having elevated white blood cell, and mostly it is neutrophilia. What's really surprising for me, in spite of being hereditary or familial, none of them has transfused to acute leukemia. So we might having something special in this situation. Now, in the ASH, actually the papers, in the ASH and in the international conference are very scarce concerning chronic neutrophilic leukemia. In the ASH, not this year, the last year, they tried in a very nice paper, gathering 94 patients with CML. They found that more than 3/4 are male, but they looked for what makes the prognosis worse, and they found that older age, high white blood cell count, anemia less than 10 gram, low platelet count, splenomegaly, and as I said before, ASXL1 mutation. Any of these 6 parameters carries worse prognosis for cases of chronic neutrophilic leukemia. Now, how we are going to treat? Actually, when I attempt to treat any hematological malignancy, I have to have the answer for these 4 questions. Number 1, risk stratification of the patient. What is the risk of the patient? Number 2, is the treatment indicated or can I watch and wait for a while? Number 3, is the patient eligible for transplantation? Because I might go for transplantation if I need a curative condition for the patient or high risk. And if the patient having a targetable mutation to be treated targetedly to modify the disease itself. These are the different parameters that we have now. We have hydroxyurea, interferon, JAK2 inhibitors. We have dasatinib targeting something else we will discuss in detail, MEK inhibitors plus minus something else, chemotherapy. We could have induction chemotherapy if we are in accelerated phase, novel therapy like aurora kinase, either A or B or by specific to A and B, and of course hematopoietic stem cell transplantation. This is the paper confirming the efficacy of ruxolitinib in treating cases of chronic neutrophilic leukemia. And as you see, this diagram shows that the response in chronic neutrophilic leukemia is much better than a typical chronic myeloid leukemia, and the higher the risk, the less responsive cases to ruxolitinib with chronic neutrophilic leukemia. Fedratinib, one of the JAK inhibitors other than Jakavi or ruxolitinib, showed a good response, particularly in cases of chronic neutrophilic leukemia. That's why in the plan of future research, fedratinib had been considered to be tried in MDS-MPN overlap and in chronic neutrophilic leukemia. Now, let us apply the 4 questions I said on this diagram, how to treat chronic neutrophilic leukemia. Number 1, we have to stratify the risk. Number 2, we have to see if we are having uncontrolled neutrophilia plus minus splenomegaly and symptoms. Number 3, therapy mostly with either hydroxyurea or JAK2 inhibitors. And now let us go to the targeted therapy. If we have CSF3 receptor mutation, we will consider SERC kinase inhibitor. And the best for that in the TKI or JAK inhibitors is dasatinib. And we can give again cytoreduction with hydroxyurea. If the patient have CSF proximal membrane mutation, we will go for cytoreductive with hydroxyurea versus considering JAK2 treatment. So if it is truncal, we will go for dasatinib or hydroxyurea. If it is proximal, we will go for hydroxyurea or Jakavi. To sum up, as updates by NCCN guidelines, chronic neutrophilic leukemia with CSF3 mutation, first line hydroxyurea or ruxolitinib, and second line vice versa, ruxolitinib versus hydroxyurea. Third line, prepare your patient for allotransplantation or supportive care alone. If the CSF3 unmutated, only hydroxyurea is our choice. Second line will be transplantation. In the last ASH, few weeks ago, another very nice paper showing the response of treatment, not the bad prognostic markers. They collected 44 patients, 20 of them were asymptomatic, 13 of them were constitutional non-specific symptoms, 20 of them have just accidentally having leukocytosis in the CBC. Splenomegaly was present in 2/3 of patients, hepatomegaly in 17%, and lymphadenopathy in less than 10%. Now, the white blood cell count was median 52,000. CSF mutation was present in almost 90%. And now, SSBMT1, which is characteristic of atypical chronic myeloid leukemia, made a difference in the response of therapy. And hydroxyurea alone or in combination of something other than ruxolitinib give response rate 68%. Second line ruxolitinib 39%, hydroxyurea second line 25%, and even few patients have received hypomethylating agent because they came across a couple of cases with plastic transformation. White blood cell response was more than 50% reduction, with 78% with hydroxyurea, while with ruxolitinib 60% alone. And the abnormal mutation plays very important role here. Patient with SSBMT mutation gives 0% response to ruxolitinib, while male sex gives 40% response with ruxolitinib, comparable to females gives 100%. So SSBMT, the gender of the patient, will make a difference of the first choice for treating those patients. Transplantation have been done to 7 patients, 4 were alive, and the death was 1 veno-occlusive disease, 1 CNS relapse with AML, 1 with something not related to the disease at all, and the overall survival in those patients, transplanted patient, was longer. My second challenge is what we call before atypical chronic myeloid leukemia in 2016. Nowadays, juvenile myelomonocytic have been moved to MPN, and typical chronic myeloid leukemia have been renamed as MDS-MPN with neutrophilia. In those people, CSF receptor mutation is very low, 10 to 20%, but they are encountered more with SSBMT, ATNK1 mutation, EZH2 mutation, and ASXL mutation. And as I said, this have been renamed as MDS-MPN with neutrophilia. Now, the peripheral blood and bone marrow, we will have the most important observed thing is the dysplastic changes, abnormal shape of the neutrophils and progenitors in the peripheral blood and in the bone marrow. And we have to diagnose that with absence of BCR-ABL or other markers of myeloproliferative and presence of the specific SSBMT1 and TK1. Now, the difference between WHO and ICC, again, in the WHO, I have to have promyelocytes, myelocytes, and metamyelocytes could be present more than 10% in the peripheral blood. In the ICC, they are emphasizing that cytopenia could be present as well in advanced disease. They are differentiating between what to find in the peripheral blood. In the WHO, emphasizing that basophils should be less than 2% to exclude even the possibility, remote possibility of chronic myeloid leukemia, while in the ICCI, they said that eosinophils should be less than 10% to exclude clonal eosinophilia with such condition. And of course, we have to exclude all the genetic mutations which could be due to one of the three major myeloproliferative neoplasms. The treatment is almost the same. We will go through the three questions and the treatment algorithm is the same, but here we are using in the differentiating mutation, we use JAK2 and we could use RAS. For RAS, we could use MEK inhibitors, and it is still investigational, or cytoreduction by hydroxyurea, interferon, or hypomethylating agent. For uncontrolled cases or accelerated phase, we will go for allotransplantation. Now, neutrophilia other than chronic myeloid leukemia, in the context of myeloid malignancy, of course, chronic myeloid leukemia is the first possibility. Chronic neutrophilic leukemia is there. Myelodysplastic myeloproliferative neoplasm overlap with neutrophilia, previously known as atypical chronic myeloid leukemia, chronic myelomonocytic leukemia, and we always shouldn't forget the pre-fibrotic myelofibrosis with increased neutrophils in the peripheral blood and even neutrophil precursors in the bone marrow. So, to conclude, neutrophils other than chronic myeloid leukemia exists both in MPN, MDS, and overlap. They have characteristic morphology, classification, and molecular aberration. Treatment is established for most of them, mostly dependent on the mutational status of each. Bone marrow transplantation is still the only treatment which modifies the disease and cure the patient. Drug therapy is evolving with new groups of targeted therapy in clinical trials. Some of them have been approved. And that's my last slide. Thank you very much.